Assalamu alaikum. So it's me again, and this is for the last talk of the day. And so I don't blame you all if you just leave now. And I mean, I would love to leave. Allah yatik al-afiyah. So, thank you, Dr. Tariq, for entertaining us with COVID, because we haven't been really entertained for the past 2 years. And it's not just burnout, it's PTSD. Now, since we've finished with COVID, يعني ندعو Allah subhanahu wa ta'ala no COVID actually does not return. And if it doesn't, then sepsis is back to the Hall of Fame as one of the most common causes of mortality in the ICU. So I'm just going to talk about some updated guidelines which were published recently by the Surviving Sepsis campaign. And I'm going to talk about them building up from previous guidelines. Obviously, 20 minutes is not enough to discuss the whole guidelines, so I'm just going to talk about the highlights of the guidelines of the Surviving Sepsis campaign. This was published at the end of 2021, so that's like 3-4 months ago. So first about sepsis diagnosis, and to start from the baseline, in a long time ago, before we became docs, so in 1992 and 2003, the sepsis 2 definition was invented. And that's the time when they defined sepsis as proven or suspected infection plus 2 criteria from the SIRS. And SIRS, as everyone knows, it's pretty famous. So SIRS is at least 2 SIRS criteria, which is like either temperature, heart rate, respiratory rate, or WBC count. Now, and we thought SIRS, that's what we were taught as residents. And but then in 2016, the sepsis 3 definition came along. And basically, it came along because we thought that sepsis 2 was not specific enough for sepsis. Because, for example, trauma patients would have SIRS, pancreatitis patients would have SIRS. Actually, someone who exercises would have SIRS, right? So the sepsis 3 definition was introduced, and it's the same, proven or suspected infection, but then they replaced the SIRS criteria with the QSOFA criteria. And the QSOFA criteria are HAT, HAT. You know that silhouette, right? That's the guy who died from propofol. I don't know if you guys, only my generation would remember that guy alive. Anyway, so in 2016, the QSOFA criteria, the hypotension, altered mental status, and tachypnea, replaced the SIRS. But then in 2021, we started looking, this is the latest guideline now. 4 months ago, we started looking at sepsis 2 versus sepsis 3. Ever since sepsis 3 was introduced, there's been a lot of debate and controversy. And as you remember, sepsis 3 was introduced because it was more specific for sepsis. So if you have sepsis 3 criteria, then you think this is more likely to be sepsis than if you have SIRS only. But then if you remember the ROC curve, the receiver operating curve of statistics, anything which is more specific is less sensitive. So that makes the sepsis 2 actually more sensitive for juniors in the group, sensitivity versus specificity. One of them is used to rule out, and one of them is used to rule in. So sensitivity is the best. So sensitive tests are best in ruling out, and specific tests are best in ruling in diseases. So for sepsis criteria, these are screening tools, right? And for a screening tool, you actually prefer sensitivity. So for a screening tool, you prefer to rule out because that's only screening. And then for confirmatory tool, you prefer a specific test. That's why sepsis 2 actually makes more sense. And now, based on the recent guidelines, we're recommending sepsis 2 again, as opposed to sepsis 3. So back to SIRS for the new residents. You've learned QSOFA, but yeah, hard luck. Back to SIRS. Now, septic shock definition has not changed so much. So basically, someone who's needing sepsis plus needing vasopressors or an increase in lactate despite fluids. And why we differentiated sepsis from septic shock is because of the mortality difference. So because we know septic shock has the worst mortality. Okay, so that's it for sepsis diagnosis. For sepsis management, there's a bit more talk in the guidelines. Now, again, very long time ago, in 2001, 2 decades ago, early goal-directed therapy was introduced. And at the time, Manny River, he looked at 6-hour goals, looking at CVP, looking at MAP, central venous oxygen saturation, hematocrit, and how optimizing these within 6 hours improves mortality. And then a decade later, the triad of Process, Promise, and Arise, 3 large trials, we call them the Sepsis Trilogy. They basically looked at the same early goal-directed therapy, and they compared it to protocolized care. Now, remember, that's 15 years apart, and during those 15 years, sepsis care has improved so much, and mortality has dropped so much. Actually, from Manny River, it was like around 40%, and then from the Sepsis Trilogy, it was around 20%. So sepsis mortality has improved significantly, but at least this trilogy showed that protocolized care is the way to go. Now, a year later, the Surviving Sepsis campaign produced their 6-hour bundle, and this is now the holy grail. So basically, in the first 3 hours, make sure you take a lactate level, make sure you take a blood culture, make sure you start broad-spectrum antimicrobials and start fluid resuscitation within the first 3 hours. And then in the second 3 hours, you start applying vasopressors as needed, and maybe more fluids based on dynamic measures, and remeasure lactate for lactate clearance. Now, 6 hours, maybe that's too long. So the whole bundle of 6 hours is what was introduced in 2016, was again overridden in 2018 by the 1-hour bundle, by the Surviving Sepsis campaign as well. So basically, they lumped everything together, and they advised that we start applying these within 1 hour of detecting a patient with sepsis on the medical floor or in the emergency department. So it's the same points. I'm not going to go through them again. They actually have an A3 poster on the website of the Surviving Sepsis campaign. If you guys want to download it, print it on an A3 and post it in the medical floor, it is very helpful to know what needs to be done immediately if you detect sepsis based on the Sepsis 2 definition. Now, I'm just going to go through some evidence where these recommendations came from in the protocolized care of the Surviving Sepsis campaign. Now, the antimicrobials in sepsis, this is actually have been derived from the famous Kumar study, Anand Kumar study, which was published in 2006, which actually looked at mortality by 1 hour, by the hour, as you delay appropriate broad-spectrum antibiotics. So it's not just delayed antibiotics, delayed appropriate antibiotics. So if you start appropriate antibiotics within 1 hour, the mortality is way less than if you started 2 hours or 3 hours or 6 hours. And then by 1.5 days, the mortality actually reaches close to 100%, survival 0. So that's why each 1 hour actually drops mortality by 6 to 7%. And again, this is where the golden 1 hour came from in the protocolized care. And within that paradigm of early appropriate antibiotics, now the ID in the room here would tell you, please do not start narrow spectrum in a septic patient. Now, obviously, you start narrow spectrum. This paradigm would be appropriate in a clinic, would be appropriate for a stable patient. But for a septic patient, the paradigm is totally different. You start with broad spectrum after you take cultures, and then you de-escalate based on the cultures. Make sure you take cultures before the antimicrobials. So within 1 hour, the cultures are taken and the antimicrobials are started. De-escalation is a very important point, which people are usually scared to do. Now, the last guideline in 2021, they also added some more insight into antimicrobial therapy. So, for example, they added some insight into when to start empirical MRSA coverage. And I'm not going to go through all of these, but I just put them for the sake of completion. So someone who's hemodialysis, severe illness, recent IV antibiotics, invasive devices, recent hospital admission, or past history of MRSA infection or MRSA colonization like nasal MRSA. So such patients who are in sepsis, septic shock, it is appropriate to start MRSA coverage with Vanco. Other patients, it's not appropriate. You should probably not start MRSA coverage. Or history of skin and wounds like bed sores. They also put some recommendations regarding double coverage for gram-negative rods. So not everyone would require double coverage. Double coverage is by definition 2 antibiotics of different groups. So a beta-lactam with a fluoroquinolone or a carbapenem with a fluoroquinolone. So only in places with high local prevalence, so if it's hospital healthcare associated and you have very high prevalence of MDRs or CREs, healthcare associated, broad antimicrobials within 90 days, proven infection or colonization within 1 year. Bear in mind, I'm talking about empirical double coverage and not based on culture. They also added recommendations regarding antifungals. Antifungals for Candida recommended for patients who are IV drug users, patients on TPN, being high lipid, patients who are colonized, multiple sites with positive with Candida, patients who have been receiving broad-spectrum antimicrobials within this week, patients with severe illness, patients on hemodialysis, patients with invasive devices like portacaths or Hickman lines, patients with prolonged ICU stay, like more than a week, patients who are immune compromised, like the multi-organ transplant or cancer chemotherapy, patients who have GI perforation or GI surgery, specifically at high risk of candidal infection. They also added some stuff about not the yeasts, the molds, like when to start antifungal against the molds, but I haven't included here. Now, remember, part of the, now, once you finish the 1 hour bundle, the next thing you should be thinking of is source control. And it is very important to realize that adding all the antibiotics in the world would probably not work very well in a septic patient if the source remains there and it's kind of walled off and not responsive to the antibiotics. So if it's an abscess, it needs to be drained. If it's a collection in the abdomen, patient needs a percutaneous drainage. Of course, it's going to be damage control, so it's not going to be a laparotomy in a patient who's with acute sepsis. It's going to be a percutaneous, minimally invasive percutaneous drainage, but at least just get the source controlled. If it's a central line, replace the central line. Now, some evidence regarding resuscitation fluids in sepsis as well, and this is all lumped together in one slide. So one of these fluids gets the Hall of Fame as number 1. You know which one? Number 1, gold. Okay, so the lactated ringers. And the LR, which is basically part of the balanced crystalloids, so it's not just the LR, if you have the plasmalite, for example, or the other one. There's a third one which is not available in Saudi, but anyway, so the balanced crystalloids get number 1, and this is based on 2 large trials, the SMART study and the SALTED trial, both on thousands of patients, one of them in the ER, one of them in the ICU. Both of them showed some mortality benefit, like 1%, yes, 1 to 2%. That's a very small mortality benefit, but it's statistically significant, and there is no drawback. Plus, there is difference in renal replacement therapy. The second one is normal saline based on the same 2 studies, and the third one is albumin, and albumin is based on an old study, which is the SAFE study. SAFE study was published 2 decades ago. And Voluven, which is in some countries known as HES, hydroxyethyl starch, or any starches, pentastarches, hetastarches, hexastarches, is now a no-no. And this is based on 3 large trials, starting with the VICEP, then the CHEST, and then the 6S trial. The standard amount of fluids to be for resuscitation is around 30 cc per kilo, based on all the guidelines of the Surviving Sepsis campaign, although recently we've been kind of discouraging large amounts of fluids. 30 per kilo accounts for around 2 liters. Now, the other Hall of Fame for vasopressors, which one gets number 1? Gold. Yeah, of course, Levofed. So the same trade name everywhere in the world. So levofed or norepinephrine gets the Hall of Fame based on multiple studies, mostly by Daniel De Backer, who has also done a meta-analysis with Jean-Louis Vincent, if you know him from Belgium. He's the guy with the ICSM conference, like the most major critical care conference in the world, and the World Federation. So he's the head of the World Federation of Critical Care Physicians. Anyway, so Jean-Louis and Daniel De Backer basically looked at the meta-analysis and showed norepinephrine having better mortality, less arrhythmias than dopamine or other vasopressors. Now, number 2 goes to vasopressin, and this is based on the VAST trial. The VAST trial was published a decade ago, which showed that vasopressin does not produce mortality benefit, but it produces better doses sparing to levofed. So if you give vasopressin, you can actually wean levofed much faster. The third medal goes to epinephrine, and that's based on one small study by Djali Anani, like 400 patients. Djali Anani is the steroid guy, if you recognize him. And basically, he showed epinephrine to be equivalent to the others as second line. Dopamine, phenylephrine, well, phenylephrine has evidence lacking. Dopamine, we think it's a bad drug. So please do not use it as first line. You can use it as fourth or fifth line if your patient is dying anyway. Or you can use it for chemical pacing for bradycardia, but not as a vasopressor first or second. Now, the goal is MAP65 based on all guidelines, although one recent study showed that MAP60 could actually be equivalent mortality with less vasopressor doses. Now, evidence for steroids, this is not within the 1 hour bundle, but remember steroids have got the pendulum effect, where every year there's a study that says, this is good, and then the next year, this is not good, this is good. And so the last 2 studies in 2016 and 2018, the last 3 studies, high press approaches and adrenal trial, basically, if you lump sum all of them together, you would probably use hydrocortisone for patients with refractory shock, like on high-dose vasopressors. It will decrease time to vasopressors, but mortality benefit is in question, because some studies say yes, some studies say no. But there's probably little harm of adding them. That's why we add them liberally. Lactate, you have noticed that lactate goes into the 6 hour bundle, the 3 and 6, and the 1 hour bundle, and repeated lactate as well. So lactate has the best evidence in critical care. We just love lactate. And you notice that lactate is associated with mortality, whether the patient is in shock or the patient is not in shock. The higher the lactate, the higher the mortality, regardless of what the patient has. It's just like troponin. It's a very important prognostic marker. Actually, there's one small study which was published a decade ago that looked at lactate clearance. So if you use lactate clearance more than 20%, 2 hours apart, this actually gives you an indication that you're doing a good chance of resuscitation and your patient has a better chance of survival. If you don't like lactate, well, look at this study. This is the most recent study which was published just before COVID. That's 3 years ago on 400 patients, and they looked at capillary refill compared to lactate. Lo and behold, capillary refill actually, depending on it, produced better outcomes than depending on lactate clearance. Well, that's one study, but it's I think it's eye-opening. And that's it. Any questions?